From Diamond Pharmacy and Optics, this is PodcastRx with Chris Bender. When he's not on the mic, Chris is a clinical pharmacist with the Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. He routinely helps providers in correctional and long-term care facilities make better medication decisions to improve patient care. And we're so happy that he's sharing his expertise with you.
Hoping that today can be a real knowledge booster.
A classic Batman and Robin or Jordan and Pippin type scenario.
A full armamentarium of options that clinicians can choose from.
For this episode, Chris takes an eyes wide open look at insomnia, particularly as it affects older adults. We talk about causes, the first line importance of non-pharmacologic treatment, and of course the primary medications used for sleep onset and sleep maintenance, and their clinical and cost considerations. We also digress briefly into insomnia management in the corrections environment, and explore natural and over-the-counter remedies. All this plus the latest medication news and a brief history of hypnotics. I'm Adam Campbell, and welcome to PodcastRx with Chris Bender. Well, good morning, Chris. How have you been? May's been quite the whirlwind month. We're finally getting together here. It's almost June, actually, but you've had a lot going on.
Yeah, it's been a crazy month. I know we're recording toward the end of May, but as I always like to say, better late than never, right?
Wow. Okay. I'm clipping that for future, for the future show intro. Okay. All right. I'll give you that. I'll give you that one. I have something queued up for later myself, but I don't think I'm gonna resist temptation. Anyway.
Sometimes you got to come out the gate swinging, man. But no, I've been good. I've been good. How about you?
Oh, hey, can't complain. It's like we were talking before I hit the record button, kind of back walking into summer here. It doesn't feel like summer physically, weather sense, but also just here we are. We're going to be halfway through 2025. I don't know where it goes, but
we're here. We're here for the ride regardless.
We're here for the ride regardless. And yeah, today's show is going to be anything but a snooze fest. I can say that.
Ooh, nice one. All right.
That's as far as I'm going to go with that kind of stuff. All right. Well, anyway, among all the, like I said, you've been keeping busy in May. One of the things you've been doing though, is you gave some presentations lately at Diamond's first long-term care conference, long-term care educational conference of the year that was in Lancaster, PA. Anyone who's listening is unfamiliar with what those are. These are conferences, free events that provide continuing education credit for professionals in the long-term care space. So you're registered nurses, nursing home administrators, personal care, assisted living administrators, people that work in that space. And so it's a full day of continuing education courses and a variety of topics. And you and one of your optics colleagues, Stephen Ford, got to go out there and give some presentations on some topics, one of which we're going to talk about today, which is insomnia management in the older adults. And I wanted to ask, Chris, primarily you're addressing needs of a correctional healthcare audience. So how does it feel when you get to go out there and talk with long-term care folks?
Honestly, it's a really nice change of pace. That's why I love that we do these every year. And I've been fortunate to be able to do, I would say, most of them throughout the years. I think it's just like like I said, it's a change of pace. You kind of get to talk about some slightly different subject matter than we might be talking about in the correctional space. Specifically, you kind of focus a lot more on like the elderly population. Another thing too is because you're speaking more to probably like nursing staff in this type of conference, I kind of get to focus more on like medication administration, weird sort of logistical considerations, kind of like the nuts and bolts of pharmacy, if you want to think about that, like how to give this, how to avoid pitfalls, what to do if they can't swallow medications, right. What kind of alternatives are around. Whereas, whenever I'm speaking in the correctional space, I'm probably focusing a little bit more in terms of like pure guideline driven clinical approach to how to treat a patient. And that doesn't lend itself all the time, not at least in the time allotment, to get down into the nitty gritty of like, hey, what capsules can be opened? Are there alternative administrations and stuff? So I really like this because I kind of get to put that little hat on. So it's nice.
Yeah, that's awesome. And of course, on top of that, I love your presentations because it's an automatic podcast topic, basically, because you're very much, you have your finger on the pulse of what's going on. I mean, anytime you give a presentation, it's like, oh, that's a really neat, relevant topic that we really haven't thought too much of. and devoted much time to on any previous episode. So it's always grist for the mill for new podcast episodes. So we're gonna
exactly.
So we're gonna you gave a presentation on insomnia, and we're gonna talk about that today. The pharmacological dimensions and treating that. A lot of interesting stuff. Very interesting and complex topic that, of course, we'll never have enough time to go fully into, but we're going to, of course, serve up a good primer and delve into that as best we can here in the time we have. So before we get into that, though, before we get into that insomnia discussion, we do have to take a look at the major medication news from recent weeks. It's time to go into the clinic.
All right, let's go indeed. So while this month's clinic may not be as robust from a general perspective, there still are some noteworthy developments that I wanted to highlight. So first was the approval of fitusiran injection, which is sold under the brand name Qfitlia. Now it's been approved as a prophylactic therapy to prevent or reduce bleeding episodes in individuals 12 and older with hemophilia A or B. Now, hemophilia is typically treated by replacing the missing clotting factor, which in this case would be factor VIII. However, in some cases, the body can actually start to develop neutralizing antibodies, which may be referred to in the medical community as inhibitors, that actually kind of neutralize and inhibit the replacement factor that you're giving to the patient. So in these cases, these patients will typically need alternative agents that actually bypass this inhibition. And these good examples of these are things like factor VIIa products, as well as the monoclonal antibody Hemlibra. And now we have Qfitlia. So Qfitlia specifically is approved for those with or without inhibitors. However, given that it's likely going to be the most expensive agent for hemophilia, it's also likely going to be reserved for those with inhibitors for whom Hemlibra was ineffective. Because, of course, for those without inhibitors, we would just continue to use factor VIII products as they're likely going to continue to be the most cost-effective option. Now, in other news, Dupixent has been approved for yet another indication, bang up job. This time it's for the treatment of chronic spontaneous urticaria, better known as chronic hives. This was, of course, based on the results from the Liberty Cupid trials, which showed significant reductions in itch with Dupixent compared to placebo. Now, these results undoubtedly come as good news to those struggling with this condition, but honestly, they leave a little bit to be desired, at least for me, given that there are already established treatments against which this could have been compared. So for reference, the general treatment algorithm for chronic hives is to start with a second generation H1 antihistamine. So think like cetirizine or loratadine, like Zyrtec, or Claritin. Now, if those aren't effective, that dose could actually be increased up to 4 times the normal dose that you would typically use for allergies. And of course, you could also consider additional agents to add, such as an H2 antagonist like famotidine, montelukast, and even a nighttime first generation H1 antihistamine like Benadryl or diphenhydramine. But of course, for refractory cases, stronger agents could be considered, like some anti-inflammatories like sulfasalazine, even immunosuppressants like cyclosporin could be used. But then more likely, we're going to start seeing the use of biologics in these refractory cases like Xolair and now Dupixent. But next, there has been some updated guidance put forward by the European League Against Rheumatism, or EULAR. It's probably one of my favorite societal names in medicine, regarding the use of anti-rheumatic drugs in pregnancy. Now, this type of guidance has actually been a long time in the making, mainly given the fact that many of these agents, particularly the biologics, are newer, relatively speaking, and unfortunately, they haven't had the most robust data in the pregnant patient population. Now, fortunately, based on EULAR's review, many commonly used agents can safely be used during pregnancy. So these include the TNF inhibitors like Humira, IL-6 inhibitors like Actemra, IL-12/23 inhibitors like Stelara, and IL-17 inhibitors like Taltz. Some can be used only if no other options are available. These include the IL-23 inhibitors like Skyrizi. Meanwhile, others should be avoided due to known teratogenic effects, meaning harmful effects on the fetus, like methotrexate, or others should be avoided simply due to the lack of data. And these include the JAK inhibitors like Rinvoq and Otezla. Because this was such a long list of medications and honestly a really well put together table, I encourage listeners, if interested, to take a look at that. The link will be provided in the show notes. And finally, ACIP voted to lower the eligibility age to receive the RSV vaccine. So specifically, ACIP voted to recommend that high-risk patients ages 50 to 59 be vaccinated for RSV. So previously, RSV vaccination was recommended for high-risk patients 60 to 74, and of course, all individuals 75 years of age and older. Now, I should note that this technically is not formalized yet, as ACIP recommendations are not considered final until they're published in the Morbidity and Mortality Weekly Report.
Let's take a quick break.
Everyone knows that pharmacists dispense medication, but the clinical pharmacists in Diamond Pharmacy's optics team dispense more potent resources, information, and education. The optics pharmacists are frontline medication experts for Diamond's many institutional partners. Whether you work as a provider in corrections or long-term care, the optics team is standing by to answer your on-demand medication questions. But optics is far more than a drug information hotline. They also create proactive knowledge resources like webinars and this podcast to keep partners up to speed with the latest drug developments. And they help providers to better manage costs and therapeutic outcomes with their in-house medication surveillance monitoring program. Learn more about the optics team by going to diamondpharmacy.com and clicking the clinical support tab. See pharmacy care more clearly with optics. Let's get back to PodcastRx.
Okay, Chris, today you're going to talk to us about insomnia, particularly as it affects older adults. I got to ask, what was the impetus for developing a presentation and now, of course, our podcast around this topic?
Yeah, so, to put it at its simplest, insomnia is a fairly common condition, particularly in older adults, which obviously make up the vast majority of residents in the long-term facilities we serve. Now, unfortunately, it's often underdiagnosed and undertreated in this population. And when it is treated, it's often not treated as well as it could be. Now, to be fair to the providers, insomnia in the older adult can be particularly difficult to treat as our sleep needs and our sleep structure change as we get older. But it's important to adequately address insomnia in this patient population since it can lead to serious consequences down the road, like falls and even other complications like depression.
As a clinical pharmacist, what about insomnia and the treatment of it do you find especially interesting, compelling, challenging?
So this is going to kind of sound counterintuitive, but I find insomnia so interesting because it's really best managed, if possible, without the use of medications. Since medications, especially in the older adults, can result in next day sedation, increased risk of falls, and even abnormal sleep behaviors like sleepwalking. Now, additionally, many medications are associated with rebound insomnia, which is actually a worsening of insomnia upon discontinuation of the medication. So I think that insomnia is much more akin to something like antimicrobial stewardship, which is essentially ensuring the judicious and appropriate use of antibiotics to prevent eventual bacterial resistance. Now, pharmacists have played a role in antimicrobial stewardship for quite some time now. So I think this is just another area where pharmacists can be involved to ensure that medications are only used when appropriate, and when they are being used, we can kind of tackle the challenge of determining which medication to use.
Yeah, we've certainly heard a lot about antibiotic and antimicrobial stewardship on this program with your colleague, Deborah Melito. And I think you're really onto something with the insomnia sleep stewardship, if you will.
Yeah, absolutely.
Well, let's start with understanding the precise clinical definition of insomnia. At what point does, tossing and turning a few nights a week turn into a certifiable condition that requires intervention?
Yeah, and well, it's obviously important to highlight this distinction because, of course, we all have sleep difficulties from time to time. But true insomnia is actually considered to be a difficulty falling or staying asleep that results in daytime impairment, and then this has to occur at least 3 nights per week. For at least 3 months. And then, of course, it cannot be explained by other exacerbating factors like underlying conditions, medications, or any type of substance use.
3 nights per week for at least 3 months. I just have to say, I love a good rule of 3 whenever I'm trying to understand anything. So
yeah, I like it when they keep things simple for you. So easier to commit to memory that way.
Absolutely. Well, what are some of the more prominent causes of insomnia that you're seeing?
Yeah, so some are situational. So think like napping too much throughout the day. That one kind of seems intuitive. Shift work, excessive stress, but even eating or exercising too close to bedtime can be too stimulating. Medical conditions, of which there are many, can also play an underlying role. Now, I typically conceptualize these as either being psych related, so more like anxiety, depression, mania, or schizophrenia, or even conditions that would make you feel uncomfortable while you're trying to sleep. So a lot of these are like heart and lung disorders, chronic pain disorders, of course, GI disorders, or even movement disorders. Think like restless leg or Parkinson's. That, of course, is going to kind of keep you up, make sleep a little bit more difficult to achieve. But additionally, there are many medications or substances that can be the culprit as well. And these are typically your stimulating agents. So think albuterol, steroids, nasal decongestants, ADHD medications for sure. But even natural products like ginseng have a stimulating effect as well. And then, of course, we can't avoid be remiss if I didn't mention caffeine and nicotine as well, because those are two big culprits.
Yeah, the former has definitely contributed to a lot of, not true clinical insomnia over the years for myself, but yeah, definitely can't leave that one out. You had mentioned earlier that insomnia in older adults is often undiagnosed and untreated. So why is this?
Yeah, so I was thinking about this, and there's probably not one good answer for it, but it's likely underdiagnosed because it's easy to assume that an individual isn't getting good sleep because simply that's what happens when you get older. And the complications of insomnia, like I had mentioned before, like depression, they're relatively common in the long-term care space. So they may be mistaken as their own primary conditions and not the result of an underlying condition like insomnia.
You also outlined that insomnia is best managed without the use of medications. And indeed, non-pharmacologic interventions are the first-line treatment for insomnia. So can you give us an overview of these primary non-pharmacologic interventions?
Yeah, so non-pharm interventions have actually been proven in clinical studies to provide better, longer-lasting effects than medications. But as with any lifestyle modification, of course, it can be difficult to implement and maintain. Now, that being said, there are two basic components that are used for insomnia. First is sleep hygiene, and the other is cognitive behavioral therapy. So I want to dive into those two things respectively. So sleep hygiene, in all reality, is just the concept of establishing good sleep habits. So you want to reserve your bed. You want to reserve your time in bed only for sleeping, so that your body maintains that association between bed and sleep and not start to associate bed with TV. And you should keep a regular sleep schedule so that you maintain your body's natural circadian rhythm. We also want to minimize stress. So you want to remove the clock from the room because that can be stress inducing when we see that we only have like 6 hours before we have to wake up. And we want to avoid caffeine, nicotine, and alcohol, especially closer to bed, like I had mentioned before. And also don't overlook the importance of a comfortable environment. So we want to make our bedroom our sanctuary. So you want comfortable bedding, comfortable lighting, temperature, and for some of us, that even includes sound. So sound machines and whatnot can certainly help from that perspective as well. Now, the other thing that we mentioned was cognitive behavioral therapy. This is more a suite of tools that are designed specifically to improve sleep by addressing the body and the mind. So it's kind of like a holistic approach. So the first component is cognitive therapy, which addresses dysfunctional beliefs and attitudes about sleep. This component, in my opinion, would be particularly useful with those with more of like an anxiety-induced insomnia. Now, the main drawback to cognitive therapy is that it requires a trained professional. However, there are now websites and apps available to provide this service if anyone is interested. The next component is stimulus control, which admittedly is kind of similar to sleep hygiene. So they recommend maintaining a consistent schedule, go to bed only when tired, get out of bed if you're not asleep in 15 to 20 minutes, and of course, reserve the bed only for sleep and sex. The next component is sleep restriction, which is probably the wildest sounding one on its face and can also be the hardest to implement. So essentially, the goal is to increase sleep efficiency. You want to spend the majority of your time in bed actually sleeping. So to do this, you should initially restrict the time in bed to the number of hours of actual sleep. So for example, if an individual is in bed for 7 hours, but only sleeps for 5 hours, then the following night, the sleep window should be restricted to only 5 hours. So that person only stays in bed for 5 hours. Of course, this is going to lead to decrease in total sleep time the following day, but efficiency should increase over the following days. Now, if the individual sleep efficiency remains less than 85%, then they recommend that the sleep window should be further reduced by 15 to 30 minutes until that goal of 85% is achieved. Now, once that goal has been achieved, of course, the sleep window can be gradually increased by 15 minutes each week until eventually you can go back up to 7 hours in bed, and theoretically you will have trained yourself to be sleeping nearly all of those 7 hours in bed. Now, this strategy, of course, can be difficult given the need to keep a sleep diary. You have to be very well aware of how much you're sleeping and how much you're awake, which can be tedious. And of course, it may not be appropriate for everyone. I'm particularly thinking about those with underlying psych disorders, because that could probably exacerbate that to some degree. So that's why I say it's kind of the wildest one on its face, but when implemented appropriately and safely, it can be a highly effective tool. And then the final component is relaxation therapy. Basically, this uses techniques such as progressive muscle tensing and relaxing, guided imagery, box breathing. So like breathe in for 4, hold for 4, breathe out for 4, and then pause for 4 before breathing back in. And then, of course, meditation can be included in that as well.
Yeah, and I've tried some. I'm not actually have any sort of definable clinical insomnia in the past, but I have found that those breathing techniques and kind of a hodgepodge of that and meditation principles have been effective for me in the past when just struggling to just stop your mind from racing. That those things are really effective.
Mm-hmm. I actually do employ that too. Like as with you, I don't have like underlying insomnia, but of course there are times when you have something going on and you're like anxious about something and you're thinking about something. I actually can feel my heart rate be elevated. And from what I found is the box breathing, it really helps to lower your heart rate. And that automatically just like, I'm out at that point. So if something's racing on your mind, even if you don't have true anxiety, but you have something coming up tomorrow or whatnot, box breathing can really help get your mind off it because you're focused on the breathing. And it can also lower your heart rate, which is going to put your body into a more natural state of relaxation. So that one to me is a huge one if you were to employ anything from that.
Right. Now, if we're talking about stressful situations, I do want to make a quick digression here in that in optics, as we said, you're primarily focused on correctional health needs. And so even though this insomnia presentation was for a long-term care audience, I do want to take a moment to ask, how often are you addressing insomnia concerns with providers for the corrections environment?
Oh, man, all the time. I mean, you have to think about it. Like, not only is the correctional setting a high-stress environment on its own, but of course, incarcerated individuals are going through a lot of stress given their potential legal situations, life outside of the correctional setting, and whatnot. So, these individuals are often requesting medications to address their sleep troubles. Now, generally speaking, correctional facilities, and I would say particularly jails, they want to avoid using medications for this because typically this type of insomnia is more acute, meaning it's more of a short-term adjustment related insomnia. And from clinical guidelines and medical literature, acute insomnia typically does not require treatment, since it's more the result of a transition or an event in the individual's life. So, because you may be in a position or at a location for 2 weeks, on average, when you're looking at a jail setting, that can be really stressful, but it's also a transient, at least in some cases, a transient situation. And in those cases, medications wouldn't necessarily be warranted. So,
well, for those times then when medications are warranted, if the first line non-pharmacologic interventions aren't working, let's get into those pharmacologic options for insomnia. When you consider how many types of quote unquote sleeping pills are available, their precise indications, drug interaction potential, varying efficacies, adverse effects, you name it, clinical decisions can get pretty complex. But there is one overarching concept that you pointed out in your presentation, and that sort of helps simplify the use of them, and that is lowest effective dose, shortest duration possible. So, Chris, please give us a quick breakdown of the major drug classes for insomnia and how they act to bring about sleep.
Sure. So, let's start with the first class of drugs. The oldest class of drugs that are technically approved for insomnia, and those are the benzodiazepines. So examples of benzos used for insomnia include triazolam, temazepam, and flurazepam. But temazepam is probably the most common in this situation. Now, these agents work by binding to GABA receptors, and in turn, they increase inhibitory signals, and hence they induce relaxation and sleep. Benzos are they're a low-cost medication, and they're effective for both sleep onset and maintenance. But of course, they're hampered by their adverse effect profile, which includes CNS depression, falls, respiratory depression, as well as rebound insomnia. And then we can't overlook their risk for dependence and abuse. The non-benzodiazepines, which include esopiclone, zaleplon, and zolpidem, they also work on GABA receptors, but only the type in the brain. So they're expected to they were basically developed and expected to address insomnia without the physical effects like falls and muscle weakness that we saw with the benzos. Now, generally, these agents have a shorter duration of action than benzos, so they're mainly effective for sleep onset. Now, to counter this, zolpidem is actually available in an extended release formulation, as well as an on-demand sublingual product that is to be taken in the middle of the night after waking. That one's a pretty interesting one. I've never personally dispensed that or seen that one used, but I guess it could be relatively effective, but you have to have at least 4 hours left in the night before you have to wake up, because that's about how long it lasts. Now, notably, esopiclone, which listeners may remember the brand name Lunesta and that little moth, lunar moth from the commercials. This is the only one in this class that improves both sleep onset and maintenance. Now, despite their theoretically improved mechanism, they still share a lot of similar adverse effects with the benzos. And additionally, these drugs are notoriously associated with sleepwalking and even sleep driving, which, needless to say, can pose a significant safety concern. And these two also carry the risk of dependence and abuse, just like the benzodiazepines. Next class, there is one melatonin receptor agonist on the market, and that is Remeltion. It basically works by mimicking the effect of melatonin, so it works to improve sleep onset. Now, because of this narrow mechanism, it's fairly safe and is often preferred in the elderly. However, it may not be appropriate for individuals who struggle with sleep maintenance, since it doesn't really work in the long term. Now, the newest class of agents are the dual orexin receptor antagonists, or DORAs, not to be confused with the Explorer. These include daridorexant, lemborexant, and suvorexant. And they work by stopping the activity of orexin A and B, which are responsible for waking us up. So essentially, these drugs don't knock you out, but rather they don't let you wake up, which admittedly is a little bit scarier sounding to me.
I agree.
Yeah, and as you'll see, they do have their own other side effects that could be a little scary as well. Despite the fact that they work more on the waking up side of things, these agents are actually effective for both sleep onset and maintenance, and they aren't associated with rebound insomnia, which kind of makes them an appealing option. However, they do have some drawbacks. They are the most expensive class since these are all still branded products, and their adverse effect profile can be a bit prohibited. So Suvorexant was the first agent in this class to come out. And I remember reading the clinical trials when I was still in school, and it was very notable for causing sleep paralysis. Which is where you wake up but your body can't move. During that time, you could have hallucinations as well as complex sleep behaviors, like sleepwalking and whatnot. Again, and another thing to consider is because it has such a long duration of action, it was also associated with daytime impairment and sleep driving the following day. Now, of course, the subsequent agents like daridorexant and lemborexant, they have shorter durations of action now. So there is at least less risk for daytime impairment, but it's still something to be mindful of with this class. Now, overall, guidelines do mention that this class is considered to be safe when compared at least to the benzodiazepines and non-benzodiazepines, which is good. However, it should be noted that these agents, just like benzos and non-benzos, do also carry a risk of dependence and abuse.
Just as a real quick aside, I can see why, going back to my question about correctional environment uses, why they would be reluctant to adopt a lot of these just for all the different, dependent and abuse considerations that you have to make.
Exactly. And if we're being honest, that's probably I had mentioned more from like the clinical justification, but if we're being honest, it's probably more driven by the desire to avoid abuse and dependence. And unfortunately, the vast majority of these are prone to that as well.
Right.
One that is not actually, at least at the doses used for sleep, is doxepin, which is a tricyclic antidepressant. And this is the final agent approved for insomnia. Now, when it's used for depression, it's given at a higher dose, so anywhere from like 25 to 300 milligrams per day. However, when it's used for insomnia, it's given at a much lower dose of only 3 to 6 milligrams per day. And this is because higher doses target serotonin and norepinephrine, which is necessary for depression, whereas at lower doses, it blocks histamine, which is effective for sleep. So it's kind of an interesting dual mechanism there. Now, doxepin is mainly effective in sleep maintenance and really lacks any significant adverse effects at low doses. So it's another one that is preferred in older adults. What I would say its main drawback is, however, is despite being available as a generic, its cost is still relatively high. So even in a place like corrections, we don't see this being used all too often if an agent is being used. And there are still other agents. Our listeners are probably well aware of this, but they're being commonly used off-label for insomnia. So these include the antidepressants amitriptyline, mirtazapine, and trazodone, the antipsychotic quetiapine, and even other benzos like lorazepam. Now, generally speaking, clinical data is lacking for many of these agents. So the recommendation is that their use should be limited to those with underlying conditions for which these agents are approved, kind of kill two birds with one stone type of thing. However, I will say that a recent trial was published, I think last month, that studied mirtazapine and showed that it was safe and effective for the treatment of insomnia, which makes sense given how often it's used for that. But that being said, if and when it is used for insomnia, mirtazapine should be used at a lower dose, like 7.5 to 15 milligrams at bedtime, as it has a greater antihistamine effect at low doses, similar to what we had discussed with doxepin.
When you're focusing on prescribing for older adults, providers will consult Beer's criteria. And anyone who's not aware, just in case, that's the guide to prescribing for adults over 65. It's interesting and perhaps not surprising then that very few of the agents that you gave the explanation about are recommended for older adults.
Right. And just to kind of highlight that, only 3 agents out of all of those are recommended for older adults. So these include Ramelteon, the DORAs, and low-dose doxepin.
So as a pharmacist, then, which insomnia medications generally rank at the top for you?
I would probably say either Remedies or low-dose doxepin, and that's just basically given their preferable safety profile. I don't want to or recommend something that could potentially be harmful, particularly in an older adult. But the only issue with these is that Remedies is only for sleep onset and doxepin is only for sleep maintenance. So you can't really have it both ways with either of these agents. So for someone who needs help with both onset and maintenance, I would probably suggest a low-dose esopiclone. Again, Lunesta, that's a non-benzodiazepine, especially for like a younger adult, or one of the DORAs, probably Doridorexant, since it's the newest and has arguably the best safety profile, if you're considering that for someone like an older adult.
Well, let's switch gears for a second and take a quick look at over-the-counter and natural remedies for insomnia. You hear about these all the time, but it's always a lot of fun to just look at the esoteric nature of some of these medications that are put out there for insomnia. I mean, you're talking about things like German chamomile, skullcap, wild lettuce, passion flower, and kava, alongside more, and I put this in quotes, reasonable sounding suggestions, or I should say more mainstream, maybe like melatonin and CBD. But if I understand this right, Chris, very few of these OTC and natural options would have a real place in the armamentarium. Is that right?
Yeah. Well, first of all, I got hats off to skullcap. That's a great name.
Yeah, it sure is.
When it comes to natural supplements, I personally live by the adage of, if it worked, it would have been patented, branded, and sold it as a prescription at least a decade ago, right? Mm-hmm. But that being said, I do think there is something to melatonin and possibly CBD. So melatonin has shown modest benefit in clinical trials, with even larger effects in older adults, which is kind of reassuring. It's also safe, relatively safe, with no hangover effect. So I think it's reasonable to try it as a first option for most people before they even see their provider or consider prescription products. Now, that being said, I always think anything you're taking should be discussed with your PCP. With that being said, I do see people, when they use melatonin, they kind of just continue to escalate the dose indefinitely. But I would say that most individuals shouldn't need to go above 5 milligrams per night. You don't need 10, you don't need 15 milligrams per night. At that point, it's just excessive cost. Now, when it comes to CBD, that data is a little bit more limited. However, there have been some recent trials to suggest a positive effect on total sleep time, improved sleep maintenance, and sleep efficiency. Now, considering that CBD has relatively mild adverse effects, I think this is something that could also be considered, particularly in an individual who would prefer to use a more, quote unquote, natural product. As anytime I discuss CBD, however, I always caution individuals, if you are considering CBD, you want to look at the lab verification or the lab certification from the manufacturer. They typically have them available on their website. And this is basically just to ensure the CBD component, and to ensure that there's no THC component in there, because there have been reports of individuals receiving OTC products that had a little higher THC content in it than would technically be allowed. And of course, if that could cause all sorts of problems if anyone gets like drug tested for work or anything like that. So definitely want to make sure you're getting the correct product.
Well, and aside from CBD, there's adverse effects in these other OTC and natural agents that people might not consider. St. John's wort comes to mind.
Yeah, I know. We tend to think that because something is natural, that it's automatically safe. Unfortunately, that's not always the case. Like in the case of St. John's wort, St. John's wort is a potent inducer of metabolic enzymes in the liver, which means that it essentially can lower the levels and effectiveness of many medications. Additionally, there are other products with more overt potential harm, like kava, which has been associated with liver toxicity. And then, perhaps to a lesser degree, German chamomile, that can cause allergic reactions in those with ragweed or similar allergies. So definitely not benign medications across the board.
Chris, I want to ask, what are your ultimate take-home tips as a pharmacist for insomnia management?
So whenever you address insomnia, always attempt to rectify the underlying cause. So think medications, substances, or medical conditions anytime before starting treatment. But when treatment is warranted, begin with non-pharmacologic therapy with the understanding that sleep hygiene and cognitive behavioral therapy can take some time to be fully effective. We shouldn't expect one night of good sleep habits to fix everything. It's going to take time. It's going to take diligence, just like lifestyle modifications for losing weight. One day of good diet won't fix the weight. It's really a change in lifestyle, and that should be an indefinite change. And for those who do require medications, make an effort to only use the lowest doses for the shortest durations. And of course, don't stop the lifestyle modifications just because the medication has been started, because obviously it's the hope that medications can kind of serve as a short-term bridge as our sleep habits continue to improve, with the goal of ultimately being able to stop the medication and solely rely on lifestyle modifications in the long run.
We'll be back to close things out with the trivia capsule.
In the realm of corrections health, not all electronic health records are created equally. Sapphire EHR is a comprehensive, cloud-based electronic health record designed specifically for correctional health providers. Since 2011, Sapphire has worked one-on-one with healthcare staff in jails and prisons to develop and refine a suite of features and modules to manage total inmate patient care. From MedPass to dental care to documentation of lab results and creating custom forms, Sapphire's correction-specific features can be scaled to meet the needs of the largest correctional facilities down to the smallest local jails. And it's all backed up by 100% in-house hosting, training, and support, with a 24/7 help desk. Get a closer look at the Corrections EHR deployed in over 400 facilities across 36 states and territories. Visit www.sapphire-health.com and schedule a demo today. Sapphire EHR. Cloud-based, compatible, correction-specific electronic health records. Now back to PodcastRx with Chris Bender.
All right, Chris. So to relate back to the main discussion today about insomnia and insomnia medications, I was curious what the history of the development of these drugs looked like. Sleep medications, hypnotics. Tell me about it.
Sure. The history of hypnotics, drugs used to induce sleep, spans centuries, reflecting our evolving understandings of sleep, medicine, and chemistry. In ancient civilizations, natural substances such as opium, mandrake root, and valerian were used for sedation. The opium poppy, in particular, was widely employed by the Sumerians, Egyptians, and Greeks for its potent sleep-inducing properties. But the modern era of hypnotics began in the 19th century with the synthesis of chloral hydrate in 1832 by Justus von Liebig. Shout out to my band in undergrad, Von Liebig and the Halberters. It was later discovered in 1869 to have sedative properties and became one of the first widely used sleep aids in popular products such as knockout drops or Mickey Fins. Its long-term use, however, was limited by concerns about its side effects, such as GI irritation and the potential for abuse and overdose. But then came the barbiturates. These were first synthesized in 1864 by Adolf von Baeyer, but their hypnotic properties were not actually fully recognized until the early 20th century. Barbitol, introduced in 1903 under the brand name Veronal, became the first commercially available barbiturate. These drugs quickly became the standard treatment for insomnia due to their stronger sedative effects compared to chloral hydrate. Now, despite their efficacy, barbiturates pose serious risks of overdose, dependency, and withdrawal. By the 1960s and 70s, they were largely replaced by the benzodiazepines, which offered a relatively speaking safer profile. Nevertheless, the use of chloral hydrate and barbiturates laid the foundation for modern sleep pharmacotherapy and influenced the development of contemporary hypnotic drugs.
I'm still thinking about the trivia capsule from an episode or two ago about FDR's blood pressure management and how he was prescribed barbiturates to basically calm him down. We've come a long way.
They just basically use those things for everything.
Yeah.
To be fair, whenever your toolkit only has just a couple bottles of something in there, I mean, not a lot of options in there. So I can understand that.
Yeah. Always fascinating how far things have come. Well, Chris, I want to thank you so much again. A great deep dive today into insomnia and understanding more of the nature of sleep medications and non-pharmacologic interventions. After that long episode, I could make a joke about needing a nap, but I'll resist the urge.
You see, a nice beginning and ending pun. This is great.
That's right. As usual, please make sure you're following this show where you enjoy your podcasts, and please rate and review if you can where you listen, and certainly send us any feedback. Just reach out via email, PodcastRx@diamondpharmacy.com. We'd love to hear your feedback. And again, full show notes will be posted on diamondpharmacy.com. Go to the blog. You might have noticed in your podcast app that when this new episode dropped, that the show has a new look. And I want to give a special shout out to my colleague, the immensely talented Jordan McLaughlin, for giving the show long overdue brand refresh. And Chris, people are going to see your face on there. I think she captured your essence perfectly.
She knocked it out of the park. I told you this offline before, but Jordan's been absolutely crushing it. So I'm excited for the rebrand. Everything looks awesome. So I'm excited for listeners to see as well. So she made me look too good. I'll tell you that.
Yeah. And so, you're going to see some refreshed artwork across all the places where the show appears. So we're really excited about that. But again, please rate, review, share. Chris, thank you again so much for lending your time. And we'll be back with another scintillating, exciting episode next month.
Always glad to do it. Looking forward to it. Thanks, Adam.
All right. Take care. PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as the substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services. Find our show on Apple Podcasts, Spotify, YouTube, or wherever you enjoy podcasts. And where possible, please rate and review. If you'd like to get in touch with the show directly, shoot us an email at podcastrx@diamondpharmacy.com. Thank you again for your support.